Good afternoon. My name is Jahan Lalani, and it's my pleasure to moderate today's session. I'm a Senior Project Manager in Organ and Tissue Donation with Canadian Blood Services. First, I'd like to begin by acknowledging that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. Thank you to Paladin for their support of the Alberta Transplant Institute's seminar series. Also, a quick reminder to submit abstracts and register for ATI's Research Day, June 20th and 21st. The deadline to submit abstracts is May 15th, and links will be posted in the chat. So let's get started. It's my pleasure to now introduce our first speaker. Janice Beitel graduated with a baccalaureate of nursing science from the University of Saskatchewan and received her Master's of Science in Nursing from the University of Toronto. Currently, she is Director of Hospital Programs, Education, and Professional Practice at Trillium Gift of Life Network, where she's worked as the first in-hospital organ coordinator assigned at Sunnybrook Health Sciences Centre. She's previously held positions in critical care, clinical education, professional practice, and patient relations at Sunnybrook prior to her work at TGLN. She's participated in a number of national forums related to organ donation and currently directs initiatives to support the work of donation in hospitals in Ontario, oversees the education of TGLN staff, health professionals, and supports the donation physician program. Without further ado, I'll turn it over to you, Janice.
Thanks so much for the invitation to present. And we were asked to talk about the experience of coordinators with mandatory referral. And I wanted to share that mandatory referral for our purposes is actually synonymous with routine notification. Routine notification is the language in our legislation. And we started this journey in about 2003. So I am going back to some deep history. And Kelly will also be able to share some of that history during her the latter part of the presentation. And I do want to share that we've been employed with Trillium Gift of Life Network, which is now part of Ontario Health. Since April 2001, we moved over to Ontario Health, and I've been with Trillium Gift of Life Network since 2003 in a variety of roles, and Kelly has been also in the role since 2000, or in the organization since 2010. We don't have any conflicts of interest. So one of the things when we were asked to describe what the experience of a coordinator was like when we started mandatory referral and now, I thought that it would be really helpful for context to talk about the environment and how we actually implemented it. So I'm going to give a bit of an overview of that. And then interlaced with that presentation, I'll be giving you snapshots of the experience. But our sense is it would be helpful for you to understand some of the healthcare concerns related to the legislation back when we actually originally started implementing it, but some of those concerns remain current. To this day, we still hear some of the same concerns. And also throughout the presentation, just talking about how the difference in our experience as coordinators, as well as Kelly will share what it was like to be a bedside nurse when we first started this rollout. Ontario Health, or Trillium Gift of Life Network, we are the organization that is responsible for delivering and coordinating organ and tissue donation and transplant services across the province. And our mission is to enhance more lives through the gift of organ and tissue donation. But what are our core functions? For those of you who might not be familiar with a Trillium Gift of Life Network, we operate a 24/7, 365 provincial resource center that takes calls, and I'll be sharing some of those volumes and how they've increased over the years. We have in-hospital coordinators and call team members that are available around the clock for donation discussions. We do allocation and recovery coordination, and we work with the 8 transplant programs in the province, 5 tissue banks, and over 120 donor hospitals. But we didn't start out that way. We started with 5 hospitals, and I'll tell you more about that as we move forward with that. We provide the oversight for the organ transplant waitlist and the provincial transplant. We produce donation policy guidelines, leading practice, and provide education. We have public education and marketing who's responsible for improving and increasing the registered consent rate. We're currently at 36% in Ontario. And also they work to honor our donor families, and you'll see a little tiny picture of our medal because, of course, without our donor families and their generosity of those who agree to help others through organ and tissue donation, we would not be here. And then finally, we will look at supporting research, system performance through metrics in donation and transplant to advance evidence-based innovation and drive quality. So many of these things were actually written into the mandate and our legislation. If you're curious about what our trends were, I had to look deep in our archives for this snapshot of what it looked like prior to Trillium Gift of Life Network. So we were created in legislation in 2001 and became operational in 2003. That is what we looked like, essentially a flat line for organ donation. And so at the time prior to the change to Trillium Gift of Life Network and that legislation coming into effect, there had been a Premier's Advisory Board that said we needed an agency to actually oversee this if we wanted to improve organ and tissue donation transplant in Ontario. So early on, we knew that routine notification or mandatory referral is just one strategy to improve donation rates. And although I'm going to show you snapshots of where we've been over the years, there's been a culmination of efforts and strategies to improve that. But I do believe that the legislation was the most important to start the building block for everything that came forward. It does capture missed identification and missed approaches. And I think it also lays the groundwork for incorporating donation as part of routine, part of quality end-of-life care. And one of the things I think you're going to hear over and over again as we're entering basically into 15 or 16 years of routine notification is it is starting to develop the culture. And when people move to different hospitals, they are taking that with them, especially in leadership the positions, which really helps us maintain some of the work that we're doing even during the pandemic. So what does our legislation say? Well, our legislation essentially says, and I have this in more detail, that hospitals are required to report all deaths and patients at risk for imminent death. But they also say that hospitals must meet the requirements set forth by TGLN. So we have some conditions that have helped us a lot over the years around when referrals have to come in, who can do referrals, as well as policies and procedures and committee meetings. So that's been very useful. It enables access to personal health information for the purposes of donation. And you will hear that privacy is a frequent concern of healthcare professionals as we started to talk about routine notification and the fact that all calls and all deaths had to come into the call center. And finally, we also have a caveat that approach has to be made for consent in a manner that meets the requirements of TGLN. So that is a snapshot of what our legislation sets up in terms of working with hospitals that are designated under the Gift of Life legislation. In terms of what the routine notification and request is what we labeled it, in terms of what the actual legislation says, you can read it here. It does specifically say death and imminent death, which I think is very important. And it also enables us to get the information of the patient substitute, which is the language in our act. And again, just that piece that the contact has to be made in a manner that meets the requirements. And so that sets us up very nicely. But how did we actually roll out and start working with the hospitals? How did we get to 120 hospitals? We started with 5. And what was important is that we looked to other experiences with it. Philadelphia Gift of Life was very generous in sharing their information with us at the time about what their notification legislation had, how it gone in terms of their rollout. So we took some of their lessons. Also, just prior to us going live, British Columbia Transplant Society had shared with us that there had been some legislation in BC around mandatory referral, and that it had not gone well and had not been well received. So we knew that it needed to be collaborative. We knew that we needed to do a lot of communication and information up front. And we knew that if we were going to be a success in rolling this out with hospitals, we really had to support the hospitals in complying with the legislation. So in that way, when we talk about what the experience of the coordinators were, when we had the coordinators hired, the in-hospital coordinators, there was a lot of the infrastructure in place and a lot of the planning in place already. And what it provided was a roadmap for how to improve donation. And simply by increasing referrals initially, we were able to do that. So that's what really helped us, I think, as a roadmap for where we needed to go initially in the early days of the implementation. And we knew that we needed to talk to as many people as possible. So we did multiple channels and multiple stakeholders and audiences. We actually had a simulcast broadcast from our 5 major cities, where we had speakers in every city and broadcast that event live, which is nothing today when I'm talking to you from my home in Toronto. But of course, it was a little more cumbersome back then when we had to set up cameras and different elements. But we did do a physician forum, and we spent a lot of time on this concept of imminent death. We hit every rounds that we could in order to disseminate information. We worked with the professional associations, the Ontario Health Association, the College of Nurses of Ontario, and the College of Physicians, and the Ontario Medical Association, because we felt that it was very important that they could support their members in the understanding that the legislation was part of the standard of practice that they would be expected to do, and well within their scope of practice. Following those 5 hospitals, we learned a lot with those 5 hospitals. And following those 5 hospitals, we phased in over the next 2 years, 13 neurotrauma centers, and then 8 community hospitals in 2007. And we did that primarily through on-the-ground blitz bedside education. That was, again, before laptops. So we had large flip presentation pads where we literally went from bedside to bedside and did breaks and ensured that we hit about 60% of the staff for education to understand what was happening with the legislation and what the expectations are. Kelly's going to show you some of those tools that we use, that we've modified and still use today. So we constantly tweaked those as we rolled out hospitals and learned what might be helpful. But aside from the 15-minute blitzes, when we started to understand what the frequently asked questions were, we developed brochures to address some of the commonly asked questions. We did a learning package, and we had resource manuals. We had pocket cards and posters. And then shortly after that, we developed lanyards as well, the lanyard cards. But those were some of the things that we were able to use to help remind and prompt staff that this was now part of an expectation of their practice. And so over the years, along with many other strategies, we were able to improve organ donation rates. And you're going to see some fits and starts. Again, this is not a smooth process. We don't always see incremental improvement. We do move up and down in terms of the number of organ donors. And we also, as you can say, we started with in-house coordinators at the neurotrauma centers, and then added 8 more coordinators to a total of with the 21 hospitals. But in addition, we participated in a breakthrough collaborative. We started DCD, and there was a lot going on in terms of expanding that practice. During the time, again, it was really almost a new conversation with every oncoming nurse, oncoming physician, continued work. There was a lot of turnover, people on mat leaves who weren't aware of it, people coming from other jurisdictions or hospitals who didn't, moved into the 13 or 21 hospitals. So it was constant communication and education. So I wanted to give you a snapshot of, again, those early slides that I dug up, give you a sense of what was happening from an organ donor perspective. But I wanted to talk about now some of the information that I found looking back around the notifications to our call center. So we do accept referrals for death and every imminent death for organ. So the total notifications, you can see, went from 8,000 in 7 and 8, just after we rolled out those 21 hospitals, to now in 21-22, we are looking at over 36,000 calls for organ and tissue donation. In terms of OT referrals, organ and tissue, just for organ, we started with about 832 and progressively have gone up, and now we're seeing about 8,000 calls that we assess for organ donation potential a year. And again, those would be from our ICUs and EDs, although with the expansion of medical assistance in dying and moving to referrals from patients, for example, with BiPAP, that has expanded some of the areas a bit for organ. And I want to say that in 1920, which was our best year, we would have hit 400 donors had it not been for the onset of COVID. Although I do believe that being able to maintain numbers over 300 donors during COVID is an example of our success in itself, and how deeply culture has shifted to include donation in end-of-life care. So that is a lot of information. And again, what I want to just emphasize is that there are many, many strategies that we used over the years, and I could present on any of these that are represented as we roll them out and work to continue that culture and integration of culture. I want to say that relationship building is probably the most important piece, and that although legislation is important, and we do remind people that this is a legislative requirement to phone in, we never use that as the first reason why people are calling in. It's always around the patient's decision to donate and providing the opportunity to the family. And as I said, over the years, we've heard a multitude of concerns from our staff in the hospitals as we've rolled out to them. It's not really different. There's some nuances to emerge around timing and specifics. But overall, these are the concerns that we heard the most in terms of the reasons people, or what they talked about, the concerns that their college is okay with it. And then some concern of that is a conflict of interest in terms of actively treating a patient and then switching to end of life. And then a caveat of that is really around what is the right timing for notification. So we continue to work through that and talk to people about the timing, and continue to work through their concerns around the timing of the call to TGLN. Privacy is also a concern, and also I would add perhaps transparency with families. So when we rolled out that big leap you saw, we continue to roll out about 12 to 14 hospitals a year. And as part of our ongoing expansion of routine notification. And with those hospitals and those communities, we actually put information in the newspaper and encouraged the hospital to let the community know that we were now doing routine notification. And our public education piece was involved in some of that language. Key messages are really important that we're continue to work on time after time, and use and build. Workload is a significant concern in terms of how long does it take to call in. So we actually were able to tape our calls and understand that they usually took 2 to 3 minutes. Kelly will talk more about that. Sometimes it takes a little longer when a patient's eligible. And of course, if they're organ donors, there can be more information, if there's potential moving forward. The idea that we're burdening grieving families, again, we try to say that we are actually adding something to the situation. The death is occurring or is going to occur, has occurred, and that we're actually providing families choice when most of the other choices have been taken away from them, or we're honoring the individual's decision to donate. So that's how we work with individuals around that idea of burdening the grieving family. And then probably beyond the scope of today's presentation, but you may know in Ontario, it's the coordinators at Trillium Gift of Life Network that have the conversations with the family. And so sometimes there's early in when we shifted to that model, there are some concerns related to the role. So overall, we still hear some of these concerns, and we just had a workshop at London around clinical triggers and identifying the right time to call in with the gift trigger. And many of these concerns still were raised even 15 or 18 years after we've rolled out routine notification. So it's something that I think coordinators working in Alberta and probably other areas who have mandatory referral like Manitoba have probably experienced some of that. So that gives you a bit of the context and the overview of what we were working with and some of our early experience and results. And I think at this time, Jehan, we're going to take some questions. Is that right?
Actually, Janice, we're going to thank you for your presentation. I'm going to ask that everyone hold their comments and questions until after the next presentation, and then we'll endeavor to answer everyone's questions together.
Okay, that's great. So I'm going to stop sharing just as we switch over, and I invite Jehan to introduce Kelly.
Thank you, Janice. All right, so our second speaker is Kelly Robillard. Kelly joined Trillium Gift of Life Network in 2010 as an on-call organ and tissue donation coordinator. In 2013, she transitioned to the Provincial Resource Center as a referral triage coordinator. And from there, Kelly worked as a surgical recovery coordinator and then as a full-time organ and tissue donation coordinator in the Eastern region of Ontario. In 2018, Kelly took on her current role as the physician program lead, working with the medical director, regional medical leads, and 58 hospital donation physicians to implement leading practices in hospitals across the province. Kelly graduated with a nursing diploma from Algonquin College in 2001 and has worked in critical care, medevac, and surgical areas. Over to you, Kelly.
Thanks, Jehan. Give me one. So building on what Janice has spoken about, I'm going to go into a little more detail about the referral process. Are my slides showing?
We can see them.
Okay, sorry. And how hospital staff participate and how some of the lessons we've learned can really help support a donation culture. One of the goals of mandatory notification is to ensure that every potential donation opportunity is assessed. To meet this goal, it's really important that the bedside staff feel supported and educated about donation. For bedside staff, understanding the reasons behind the notification process builds trust in the donation system and makes notifications about organ and tissue a normal part of excellent end-of-life care. I started working in an ICU in 2006, just a year after mandatory referral was implemented in that center. At that time, I didn't really have a good understanding of when I should call TGLN or even who I should be calling. We had an in-house coordinator available during business hours, and generally, if the coordinator was on site, we would notify her. If it was outside of regular business hours, we would call TGLN, but often after withdrawal had already started. It's not part of our end-of-life routine, and it felt more of like a nice thing to do if we had the time rather than something that must be done. My perspective changed a little bit when I had the opportunity to learn about the donation process and the importance of the timing of notification. Something as simple as knowing that if I called after withdrawal had started, that meant that I had taken away the opportunity for that patient and their family to donate. I have found that really enabling healthcare providers through education about these key points leads to incorporating donation assessment into excellent end-of-life care. In Ontario, our system essentially identifies 3 pathways to donation based on the patient's situation. Notification always starts with a call. This was always my focus when educating hospital staff. The key message that I hope they left with was just call and we'll walk you through what happens next. Patients that are ventilated are assessed for organ and tissue donation at the time of the notification, and in most cases, non-vented patients are assessed for tissue suitability after death. These notifications are made based on criteria that we lay out and which we'll look at shortly. The key is that all of these patients are referred to us. Sometimes an early tissue notification might come in, and through the referral process, we end up finding out that there is organ donation potential, which is advantage of all of these referrals coming to TGLN. Initially, when we were bringing hospitals on board, all deaths had to be called into TGLN regardless of age or unit type. When the feedback from hospital staff was reviewed, the criteria was adapted for inpatient units, but it remains the same for critical care units. This is to avoid healthcare professionals screening patients where organ potential is possible. In critical care environments, TGLN is required to be notified for all patients, regardless of age, when clinical triggers are met. And for inpatient units, we require that they call for all patients 79 years of age and under within an hour of their death. For infants and neonates, the corrected gestational age of 36 weeks requires notification to TGLN, and stillbirths, regardless of their gestational age, are not required to be called. We use the call screen connect next steps format to help guide healthcare professionals who work in non-ventilated units. This is a modified version of our original referral process and is applicable, as I mentioned, to all patients 79 years of age and under. This process was modified based on the feedback, but also on tissue bank criteria. When staff make these calls, they're connected to a tissue coordinator who can expertly guide them through the next steps. Also, I've mentioned most ICU nurses start out on a floor type unit, and by the time they get to the ICU, they are likely familiar with the tissue referral process. Once they move into a critical care area, this familiar process is built upon through education by TGLN coordinators. Support staff in critical care units, TGLN has developed and modified the referral criteria, as you can see here. These guidelines, which we call clinical triggers or gift triggers, are intended to ensure that the notification to TGLN builds in the time required to assess potential donors, meet with patients and families, and optimize the potential for donation. Triggers are shared with staff in educational sessions, on pocket cards, lanyard cards, and posters throughout the critical care unit. When a patient meets any of these triggers, as Janice has mentioned, as per the Gift of Life Act, a referral to TGLN is mandatory. We also have notification triggers for patients seeking medical assistance and dying. Once the trigger has been met and a call is planned, we've developed a tool to guide healthcare professionals. Routine notification worksheet helps the person referring gather the bulk of information needed to assess patient organ and tissue donation potential. We'll have a quick look at that on the next slide. Again, referring to the Gift of Life Act, a notification to TGLN is mandatory regardless of the cause of death or coroner involvement. Janice spoke to partnerships, and we've developed a close relationship with the Ontario Coroner's Office, and very rarely are organs and or tissues now blocked for transport. Notification in Ontario starts with a nurse, nurse practitioner, respiratory therapist, or a physician notifying TGLN. The notification is a part of standard, high-quality end-of-life care, and it's the first step in the organ and tissue donation process. Janice mentioned we receive calls 24 hours a day, 7 days a week, and there's always a coordinator available to speak to staff or families about organ and tissue donation. So here we have a snapshot of the form. I won't go into detail. Feedback from bedside staff indicated that notification calls were taking a long time. In response to that feedback, this is one of the tools that we have developed and modified multiple times over the years. For everyone involved, having the information needed to assess suitability close at hand is key to shortening the length of the call. When I worked in the Provincial Resource Centre as a referral triage coordinator, my goal was always to get as much information in the shortest amount of time possible. And some of the strategies I used were to make sure that the caller had the patient's chart close at hand. And then after I collected the basic demographic data, I quickly looked for any absolute exclusion criteria, like certain types of cancer or infectious disease. Being able to shorten the call whenever I could led to more patients when the calls required more time. We also often use this slide to talk about privacy as well. Providing the information to TGLN, as Janice mentioned, does not breach any privacy laws, and it prevails over all other privacy and health information laws, and is one of the many tools that helps us to overcome healthcare provider resistance. In the case of notification for a potential organ donor, these 4 basic steps help in the process help guide both TGLN and the bedside staff. The most important step is the timely notification. Without this, in many cases, we lose the opportunity for the rest of the steps. In 2015, when I was an organ and tissue donation coordinator, an ICU physician came to my office with a last-minute referral. He apologized and acknowledged that he should have let me know earlier, and then he also let me know that the family had gathered for withdrawal. I shared with him that I was going to have to go speak with this family, and I went and spoke with them with his support, and then obtained consent for donation. Clearly, this wasn't really an ideal situation. The building blocks laid out by mandatory notification in 2005 supported the donation culture, though, and allowed the process to occur. It is notable that the physician referred despite it being late, and then supported me in speaking with the family despite the disruption that might occur. And looking back at my early bedside experience, this situation would have most likely led to the notification happening after withdrawal had started or even after death. I think this speaks to the shift towards a culture that supports donation, even in challenging situations. In critical care units, the gift triggers allow us to assess suitability and make a plan. The plan can range from the patient being completely ruled out for organ and tissue donation to daily follow-up to determine when it's appropriate to have an on-site coordinator. If there's a possibility for organ donation, TGLN will work with the healthcare team to establish a plan for when it's appropriate for a coordinator to come on site or hospital support. If the healthcare team indicates that a coordinator is not needed yet, a coordinator will call back and check with the bedside nurse each morning via telephone. During this call, the coordinator will ask for updates on the patient's medical condition, if there's a plan for a family meeting to propose withdrawal, or if the patient or family has brought up withdrawal, or if there's a plan to complete neurological determination of death testing. While we call every day to check on the patient's status, it is also the hospital's responsibility to call us if there are any major changes to the plan discussed on the morning phone call. For instance, if a patient loses brainstem reflexes or neurological determination of death testing is planned, the expectation is that the bedside staff will call with an update and not just wait for the next call from TGLN. So after all of that, I thought it was important to look at some of the lessons we've learned over time. As Janice mentioned, and I think has been mentioned a few times through the presentation, the legislation is only part of the toolkit. Just telling people that the law says they have to call doesn't actually inspire a true culture change. Teaching hospital staff about when, why, and who to call is quite important. Having resource materials like routine notification forms and clinical trigger information easily accessible increases compliance. And being able to properly plan a conversation with patients and families definitely increases positive outcomes. Speaking with a family after they've already set a time for withdrawal makes the conversation much more challenging. And finally, consistent education, modification of tools, and systemic support ensures that practice becomes consistent. My colleague recently shared with me an experience. He supported rolling out mandatory referral to an organization that had 2 sites, one with an ICU and one without. And then years later, the second site added a critical care unit, and staff was shared between the 2 units. Staff from the original site noticed that the resource materials weren't present in the unit and that routine notification wasn't happening. I really think that this is an example of the culture of supporting donation and how it was transferred to the new unit through hospital staff, which is the culture that was developed over time based on the initial rollout of mandatory. That's all I have for now, and Janice and I are happy to take any questions that you might.
Thank you both for such comprehensive presentations. If I'd like to open the room to comments and questions, so feel free to use the raise hand function or the chat box. And if I miss you, please feel free to jump in with your question as well. So it doesn't look like we have a question to start us off, so maybe I will. I'm definitely have to say I'm totally awed by the breadth of complexity that's gone into planning and implementing routine notification in Ontario. And you spoke to a number of lessons learned. And if you had a program that was exploring implementing routine notification, and if you reflect back to your experience, if you only had to pick 2 lessons learned to really focus on and support success, because there's challenges in resources and capacity, what would you pick as your top 2 priorities? Or what would you advise other programs to focus on? Sorry.
Kelly, why don't you take that one?
So in my experience, from bedside to through everywhere I've worked, I would say that the in-house coordinator, wherever possible, is quite beneficial because you can have that real-time education and also continuous education. So even where there isn't a in-house coordinator available, where we have hospital development coordinators, but the continuous education and evolution of that really supported a culture. It wasn't like a new process that came in and kind of got forgotten about over time. The reiteration of the importance really led to building a culture in the centers that I've worked in.
And I would just add like a routine, the worksheet, so staff know what to expect and what information they should have ready. That would be my additional suggestion as a tool. We all started with just that worksheet.
Wonderful. I'd like to acknowledge you've got a couple comments in the chat box that really give you guys kudos for their presentation and your process so far. Doesn't look like there's any other questions yet, so I'll just kind of keep going and encourage everyone to throw your questions to the chat box or raise your hand. I guess the next question for you guys would be, as you're rolling this out and you reflect back, were there any unintended consequences of perhaps some of the processes that you took on? You talked about some opportunities where you had staff move to other units and they got to leverage some of their previous experience and knowledge. Were there any other challenges that you guys walked into, and did you have any strategies that you used to overcome them?
I would say one was you saw we had classification for neonates, but I think when we rolled out and went carte blanche and started rolling out to all the hospitals, we didn't actually consider special populations like neonates. And so there was a lot of questions around how do we handle, do babies born still have to be called in? So there was a lot of working through that. And I guess in retrospect, I wish we had thought about that before, because I'm from an adult background. So I had thought of that. So there are always things that come up, and I think that relationship building and saying, that's really good. I'm really glad you raised that. We need to work this through. Let's talk about it. I think that could be very helpful. And Jahan, maybe you can't see, Linda Powell has actually a hand up. I can see it on my.
Yeah, I just noticed that.
Yeah,
Linda,
I
go
didn't want
ahead.
to miss Linda.
Hello, I was just typing the question. Terrific presentations, fantastic. And I think, as you may know, in Alberta, there's some legislation pending on mandatory referral, and this is really timely. And thank you for your very complete presentation. The education component is huge. I mean, emergency departments, ICU, new nurses, new residents coming on, people moving to other facilities and leaving, and new people coming in. How do you bring that all together so that there's no, or you're minimizing gaps? There will be gaps with changing staff, but how do you minimize the gaps with such a huge educational need?
Yeah, I think initially, the one thing is we still have standardized presentations, but we have set presentations that are set but centrally, and then our in-hospital coordinators initially did the education. But as part of the requirement, because our legislation says that we have a requirement, we built it in that it needs to be part of their orientation in the hospital. And in addition, now we have modules. Of course, we have a lot more ability to offer modules that are developed, but it's actually part of the continuing education in quite a few hospitals as well. And so you're right, it is an endless bucket. I have to say, because I went from an in-hospital coordinator position to an educator position at TGL, they thought they initially needed 2 educators for 2 years. And that's not what's happened. And we've grown and split. So we have our education for our clinical staff, and then we have education, hospital development, that's just for hospitals. And so you're right, but those things initially, standardized presentation, building it into orientation, doing train the trainers for the educators in the ICUs and EDs is really helpful. And of course, modules and required modules, because hospitals can put that in as part of the requirement. Did that answer your question?
Yes, absolutely. Thank you. And I have another question too, if there's no other questions.
Go ahead, Linda.
The opportunity to do public education and awareness is sort of embedded in the culture of donation. And do you work closely as well with the public education side, being clinical, or are you involved in that as well?
When we were a smaller unit, I would say I worked quite closely with the public education around the languaging, and I still do a bit of that for the coordinators. And I think we actually have one of our in-hospital coordinators on the call as well, Sue. One of the things is they often get involved with regional initiatives, so they get invited to speak at the clubs and different pieces in terms of the public. So we try to respond to that, but the public education actually developed champions and individuals and advocates who could go out and speak so that the clinical staff could be preserved for clinical activity. Because as you saw our increase, the clinical staff really weren't available to do the public education after that.
Wonderful.
Just to add to that, Janice, I would say that as a organ and tissue donation coordinator, when you could fit in the public education or some sort of experience like that, it really went a long way to kind of build relationships, but it like kind of rebuilt you. I don't even know how to phrase it exactly, but it was really nice when I could fit in the time to go do something that was related to public education or those kind of resources and meet the people on the ground.
You've both talked a lot about building relationships and the importance of it. And I wonder if you have any advice on how to position routine notification with hospital physicians where, right now they have an ability to, if there's a potential donor, they're going to assess themselves and decide whether they're going to refer or not. Where with routine notification, you're kind of saying, well, if they meet these basic triggers, you should just call in. And now you're kind of taking that purview away from them. How is that received, and how do you respond to that?
Kelly, you can start. I think you've hit then like a nail on the head and sensitive. It's like, how do you work with people? So Kelly has some good insight into working on the ground with physicians.
So having, we call them our donation support physicians available 24/7 has really been integral to this. But to be honest, it's still something that we deal with from time to time and we have to follow up on. But having our hospital donation physicians, so our 58 physicians across the province in key hospitals, being able to follow up on when this occurs actually is quite beneficial, because then we get the opportunity for education about why we're really telling them they should not be pre-screening these patients and they should be just calling us. The screening criteria changes constantly, and that was always key when I was doing education, especially with physicians, is that the screening criteria changes consistently, and even I couldn't keep it straight as an organ and tissue donation coordinator. So how could we have an expectation that they would know about what's happening? So.
Yeah, and I would just add that when I was initially training other in-hospital coordinators in the role, one of the things we would talk about is sitting down with each intensivist, because again, you need to focus on an area, and I would recommend, if possible, like you focus on ICU and then you focus on emerge. But if you can sit down with the physicians, actually one-on-one, if you can get even 10 minutes with them and say, tell me about your experience with donation, tell me what you think about donation. And then you understand where their positions from, where they're talking from, what concerns them. Maybe they had a case that went really bad in the past, and thinking about that. But it all starts with sort of understanding the other's perspective. And I think part of that ability to actually do that with each physician and develop relationships with each physician and understand what was important to them also helps them. You share information in a way that makes sense to them. So if their concern is about family autonomy, or if their concern is around timing and conflict of interest, like how can you split that? It does, I think, to be fair, people still work with different physicians differently across the province, and different things motivate people. But in addition to what Kelly said, like just those early conversations can change people's perspectives of each other. And yeah.
Wonderful, that's great insights. Linda, you have another question for us.
About the audit and data. So we had the in-hospital coordinators do chart reviews in ICUs and EDs to see if we missed any eligible deaths, and we would provide that on a quarterly basis, and usually it's a quarter late. That's always been a problem with working with deceased donor audits. Again, sometimes it's a struggle even to get quarterly. And as the coordinators have gotten busier, we actually have health record reviewers who have a medical record background doing some of the reviews now. And we also take advantage of what's in our system. but we've set up Kelly and I were talking about a high impact strategy we use with some new hospitals if they're not referring. What we do is focus on that positive. So every time a referral comes in, they get a note thanking them for the referral, even if, and reiterating that in this case, nothing came of it, but this, gives hope to those waiting. So we would do that for a period of 3 months sometimes with hospitals that weren't doing so well with referrals. And that often jump-started them. You can't sustain it. It's very difficult when you have lots of hospitals, but it can be a jump start in terms of a strategy. And
that's a great idea. And Murray also has a question there for you about your experience with IT/database tools and how that might link with the previous question.
Yeah, I think we originally used an Access database when we did health record review. When we started using iTransplant in 2012, we started putting the information from our deceased record reviews in iTransplant as well. I don't know what our IT department built the reports in, but that I could connect you with someone. I think that's my best offer, to stop talking and connect you with someone about that.
No, that's fantastic. We probably have about time for one more question. So it looks like Linda's got another question there. Do you feel that public reporting has helped the culture of donation development and contributes to increased donation rates and other metrics?
Yeah, Kelly, do you want to talk about that? What was your experience in the hospitals when we rolled that out?
So initially, I would say that there was a lot of focus on the metrics because there was some fear in the hospitals because it was being publicly reported, right? But over time, the recognition of how the stats apply to actual real-time situations, we developed more understanding of that. I will say that the most important stat since I have been working with TGLN is the eligible approach rate. That seems to be the one that hospital staff can apply to their situations most readily. So that's been very effective in moving educational plans, different ways of talking to staff, those kind of things. So I don't know if you want to build on that, Janice. That was my experience.
Yeah, so eligible approach rate was the third publicly reported metric we developed. So we have routine notification rate, which is literally eligible deaths over reported deaths over eligible to report deaths. Conversion rate, which is conversion but the hospitals like eligible approach rate because they can impact whether people are approached or not, and that's with timely referral. And so we speak a lot about, again, giving the opportunity to ensure that people can make a decision and have that. So that has been really useful. It does feel like the combination of legislation and public reporting has helped us, but again, it's really one tool to drive the hospitals forward because they're used to public reporting other things now. So I think that talking about it, the metrics, the best thing about the metrics is you talk about it. That's the biggest advantage of public reporting.
And you think it's helped your program advance further?
It has, like in terms of sharing those metrics every 3 months at committee meetings, and also identifying that if people are consistently below target, that there's conversations with leadership in the hospital. And then the one other thing I want to talk about is the celebration of awards in public reporting. So last year, 36 hospitals, I believe, were awarded awards of excellence for meeting performance and benchmarks. So again, we try to acknowledge and recognize performance. And when we do the award ceremony, we also go to the Emerge in the ICU to share the actual award. So really focusing on lives saved and how well people are doing can really drive performance as well.
Fantastic. I love all the positive reinforcements. All right, I'd like to take a moment to thank everyone for attending today's webinar. And just to let you know that next week's ATI seminar, we're pleased to have Dr. John Forsyth presenting a new legislative framework for donation in the UK. And registration details will be posted in the chat for you. Have a great afternoon.
Thank you so much for your time, everyone.